think about what types of AV access we have to use for hemodialysis patient, we can see that there's two types. The first one is autogenous axis, and the second one is non-autogenous, like prosthetic graft and biograft. There is a new graft now that starts to be used. It's called Lsmail. We start to do a research of this type in about 15 centers all over the world. About the autogenous graft, there's a forearm and arm graft. For example, we prefer all the time to do distal autogenous grafts like radicephalic. The second choice for us is a brachycephalic because of the superficial base. It's better to do and it's so easy and quick surgery. If there is no superficial base, we used to transpose the basilic vein in the forearm, also in the arm, superficialization of the vein. If we have no veins, we prefer to do brachiobasilic AV access with PTFE graft in forearm, or to do a brachiaxillary in forearm. There is no access in arm because of central vein occlusion. We do femoral PTFE graft. Sometimes we have to do another type of autogenous graft with transposition of superficial femoral vein, sometimes saphenous vein. The first thing what we have to think about is how we can deal with these patients, and I think that the ideal vascular access center should be coordinate between three teams. The first team is a nephrologist, and the second one is the vascular access surgeon, and the third one is the invasive radiologist. For example, if I have a patient with end-stage failure and the nephrologist decides that the patient needs hemodialysis, we prefer to send the patient to us before starting dialysis. If you know that your patient will need hemodialysis within 3 months, it's better to send them before any type of penalization or catheter insertion. The vascular surgeon will plan for the surgery, and after 1.5 or 6 weeks, the patient will start to dialysis through the native fistula, and by complete screening all the time by a vascular surgeon and nephrologist. If there's any problem with the fistula, we have to send the patient to an invasive radiologist to deal with this problem. For example, if there's any central vein stenosis or puncture site stenosis, we have to do PTA to save the fistula and to deal with the patency all the time. First of all, we have to know the patient, to know the prognosis of the patient, to know his risk factors, if the patient has any existence of hypercoagulability, if the patient has central lines or pacemaker, and to measure the blood pressure on both arms, see if there is any inflow stenosis centrally. The duplex ultrasound or car-coded ultrasound is the most. We usually use for planning the fistula ultrasound to do a mapping for the veins and the arteries in the arm for arm, also by using a 5 centimeter narrow with that inflated to at 60 millimeter mercury to inflate to dilate the vein. We know that better the diameter for axis creation for cephalic vein is more than 3 millimeter. Here's an example for cephalic vein at the wrist with 360 millimeter with good for axis creation. Another example for cephalic vein, we can see two branches here. Lateral and medial branch with a small diameter that should, if I can see this patient and I do for him apparently, for me the patient, the failure rate for this fistula is very high. So I don't have to leave to do for him for arm cephalic vein, cephaloidal fistula. We have to think about the cephalic to see if the cephalic vein is efficient for cephalic fistula. Also, we have to map all the veins superficially in the arm and forearm, and to see the basilic vein, to see if we don't have a good cephalic vein to transport the basilic vein to the arm or also in the forearm. Another thing just we have to think about is to mapping the artery, because if there is a stenosis or calcified artery, I know that there's a high risk for failure of the fistula or Steve syndrome. Who's the patient that need venoplasty for them before doing fistula? Any patient with a previous subclavian artery catheter, any patient with a permanent pacemaker is supposed to have, for a long time, supposed to have central vein stenosis, or any patient with arm edema with or without previous fistula. Sometimes we have to think, and there's a sixth sense for a surgeon with his experience if he needs to do the venoplasty before. If we have a central vein occlusion, so I know that it's supposed to be a complication here in the same side where I do the fistula. If there is a stenosis, central stenosis, so what do I have to do? We avoid to construct on the same side if possible. If not, if there just there's a vein there, but I have to do it at the same side. We construct the fistula at the same side, and sometimes intraoperatively we do PTA for central vein. Sometimes if we can see that there's a part of the vein with a small diameter, we can dilate all over the cephalic vein, for example, with a 4 millimeter balloon for about a length of 100 or 150 millimeter to mature it. Here's an example for a pneumatic vein occlusion previous to access circulation. On the left side, you can see the pacemaker with the left subclavian vein occlusion. Another sequel is the permanent catheter with the occlusion of the pneumatic vein. So on this side, we know that we can't deal with this problem, or we can't create a fistula on the right side. Another example for both central vein stenosis, I know here that there is no way to do or to create fistula in both arms. So we have to do another venography, IVC to see the femoral veins and iliac veins, to see if it's patent, and to think about the transposition of femoral vein. Okay, here's an example for cephalic axis creation. In general, we do all our fistulas under regional anesthesia. We do supra and infraclavicular block also locally. There's no need to do general anesthesia for this patient. After mapping that, and we already do another mapping intraoperatively. We used all the time smart to squeeze the blunt and with the endovascular bead. Here's the anastomotic side. Here's the fistula after 2 weeks with the maturation. What we have all the time to do ultrasound. The ultrasound also be done with a vascular surgeon all the time. We have to see that if our fistula is mature. The sign of maturity is that the diameter of cephalic vein become more than 6 millimeter. Also, the flow rate in the fistula more than 600. For example, we have here 1300 millimeter per minute for this fistula, for the cephalic fistula. We think that it's mature. We mark the sites of the puncture and we teach the patient and nurse team in dialysis units how to puncture this site. Another example of construction of fistula, for an example here, pericobasilic fistula, we used to use taber PTFE 4 to 7 millimeters. And here's a sequel, just we have to do, as I said before, ultrasound all the time to see that any problem with this fistula. For example, this patient become bleeding, continuous bleeding from puncture side. We did from him ultrasound that showed that there is a tight stenosis in the venous lymphatic side. Here's the lymphatic side. We have a chart all the time. We have to chart before the surgery, the veins at the time of mapping. After that, all the time, just when I do ultrasound, I have to draw the fistula to sign where's the stenosis. For me, it's informative. For the interventional radiologist, also informative. You can know where's the stenosis and from which side he can puncture and to PTA. This is a venography for this patient. We can see that there is no central venous stenosis, but we see here that there is a mild stenosis at the arterial puncture side, and here is the slight stenosis in the venous side. We did here a balloon, high pressure balloon, 40 millimeter balloon, and this is the result post-PTA. And another type of fistula we use, if we don't have any superficial veins, for example, cephalic vein, we used to use to construct a basilic vein with superficialization of the basilic vein by tapping skin incisions, not all over, to do long excision, and to superficialization of the vein. Here's the fistula after superficialization of the its nature. Okay. I will present a complication of every fistula creation. Every patient, we create for him, construct for him a precursoric fistula with the superficialization of the vein. Here we can see 4 days after the surgery that his arm becomes swollen and there is sloughing of the skin here. Here's the venography before the creation of the fistula. We didn't see any stenosis, central stenosis here, but sometimes we have to think about functional stenosis. When we have high pressure in the fistula, we think that there's maybe functional stenosis. There's a high flow in the fistula. It's sometimes we didn't see the mild stenosis that become more severe with high flow in the fistula. So we did for him another venography, and the venography showed that there is a severe stenosis in the cephalic vein. We dilated with high balloon pressure, and here is the fistula. After 14 days, we removed that catheter, and we can see here 14 days after the surgery that the edema resolved, and 2 months after the surgery, the patient started to puncture the dialysis via fistula in the arterial side, arterial puncture side, and the venous puncture side. Another problem when we construct a fistula, with non-appropriate arteries or inflow stenosis in the artery is still simple. Here, for example, we have here brachycephalic fistula with non-healing wound in the finger. We did for the patient at aortogram to see if there is any stenosis centrally. There is no subclavian artery stenosis. Here we can see the brachial artery. The brachial artery is normal, but here we can see the very calcified radial and ulnar artery. So what we did for him, we did a banding just to decrease the flow in the fistula, and it's sometimes the resolution of to reduce the flow. Sometimes if there's a necrotic wound and we just afraid that the patient may need amputation, if we can wait, we close the fistula. Here's the fistula, the hand after the banding. Another life-threatening condition is infected partial puncture site. Sometimes we can see this patient all the time, and we can see a small necrotic because the skin in the puncture site is a small, but in the inner side we can see wide, for example, wide hole in the inner side with a clot that sometimes the clot is just moved from the side and the patient start to bleed. We saw patient is when I saw a patient, he didn't come to the hospital, he's free, but on the way to our hospital, and he died in the bus with a massive bleeding from the such puncture site. There's another patient from Gaza. We deal with him. With a severe hypertension at the venous hypertension at the puncture site with necrosis. He was intubated, and we did for him. If you can see here that there's a severe swelling at the arm with a necrotic tissue at the site of fistula creation. We did a sonography and we saw that, noticed that there is a severe stenosis in the cephalic vein or the luminate vein. We did a balloon angiography as the first step. Here's his arm after the post-deployment. We did angiography transfemorally for him, and after that we closed the fistula, and here's the arm after 1 week after closure of the fistula.
You have 5 minutes. You have 5 minutes.
Okay. Here's the fistula after 2 weeks. Thank you for the first one. Okay. Okay, I will start with the study because we have time. We did a study just to see if there is any benefit for creation of or for construction of a fistula for elderly patient older than 80 years. The aim of our study is to study the success rate of vascular access in hemodialysis in elderly older than 80 years. And to review the kind of vascular surgical access in this age group and patency rate of different types of accesses. A total of 134 patients were included in this study, retrospectively from January 2005 to December 2009, with mean age of 84 years old. 134 patients underwent 146 vascular access, including native or graft. We can see that most of the patients suffer from hypertension, about 40% suffer from diabetes. With yet 128 native fistula and EBTT graft for 18 patients. Most of the native fistula were brachycephalic. As all the 146 fistula followed by the physical examination and Doppler ultrasound to evaluate the patency rate. The primary patency rate was 39% at 12 months, and the functional patency was about 92%. With the graph that showed the patency rate and primary and functional patency. 18 were every fistula with PFE. The primary patency also showed that at 12 months there was 36 and functional patency 94. This group is too small for statistical significance for discussion after 6 months of follow-up. Here's the graph that showed the primary and secondary patency of this type of fistula. We noticed that the primary patency, there is no statistical difference between the primary patency and secondary patency for all types, for native fistula and also graft. For brachycephalic fistula, we created 91. The primary patency was 40% at 12 months and 92% for after 12 months as functional patency. If the brachycephalic fistula with the graph that showed primary and functional patency. The patency rate also at for brachycephalic fistula 4 months, 12 months showed that there's 36% and 93%. Here's the graph for the patency. We also noted that there is no statistical difference between two types of fistula creation between the brachycephalic versus brachycephalic fistula. Also, we noted that diabetes does not affect the fistula. Here we can see that there is no statistical difference between all types of fistula creation for primary patency and functional patency. Out of 128 native fistula, 3 were unnatural. All non-natural fistula were radiocephalic. 1 native fistula from both before starting dialysis with early failure. 4 patients, about 3%, with total early failure and non-natural 5, about 5.4%. 15 patients with the fistula had a delayed maturation or non-maturation. 11 of them with fistula. 9 patients underwent balloon-assisted maturation, of which 7 matured. 2 failed to mature despite the intervention. 4 for fistula failed to mature. 1 matured after an additional time interval. The relative risk factor delayed maturation or non-maturation for forearm fistula was 13%, and compared to the brachycephalic fistula was 12%. Overall, the occlusion rate was 13 out of 128, and out of 146 patients, 76 underwent 198 angioplasties and an average of 2 angioplasties per patient. We can see that the median survival for this age group was 38.2 months. In conclusion, there is no age limitation for vascular access, and diabetes does not affect the failure of vascular access, and there is no difference between brachycephalic or radiocephalic access for elderly patients. Patency of early access looks same with younger age group, and early access prolongs your patient survival. So you have to think about creation of fistula for elderly patients. Thank you very much.